our members to figure out what tools and resources that they need to advance practices in these new settings. So what I'm going to talk about today is a little bit about the scope of practice, how acute care might differ from ambulatory care, looking at some of the activities that you may be doing or need to do to expand your services, but my main focus will be on this transition to pharmacist roles within ambulatory care settings. Now here's a statement that I want to show that practice will change. And this was the Pharmacist Code of Ethics back before 1970. And there actually was a statement on the book that referenced that pharmacists will not speak to patients about their medications. And when I was in pharmacy school, we actually learned about placebos. And once in a while, we would be asked to spell placebo backwards so the patient wouldn't know what they were receiving in case they had figured out what placebo was. So sometimes we didn't even tell our patients what they were taking, much less talk to the patients about their medications. But this has changed significantly. Obviously, this whole conference is talking about the role of advancing pharmacists in advancing care and changes that we need to make within our infrastructures, whether that be at the academic level, whether that be at the collegiate level or the practice level, or whether that is at the organizational level, that we need to figure out what's going on. And the quote I have on the slide is from Bill Zellmer that mentions that if we want to bring about change within a diverse profession such as pharmacy, we need a large number of people moving in the same direction. And without this, we're not going to move our practice forward. And I think, again, this conference today and the theme of the conference today and all of our lectures really focus on this, is we're all on the same page, moving our profession forward. So what are some of these trends that say that we will change our practice? One is technology. It's changing incredibly fast. There's ways that right now you can get all the information that you need about your health on your smartphone. It can monitor your blood pressure, it can monitor your glucose levels, it can send reports to a remote area. As practitioners, we need to figure out what are some of these tools that our patients have and how do we utilize those to help the patients improve their care. We're seeing healthcare reform. This was referred to in a talk this morning that within the United States, we do have healthcare reform going on. And I'll tell you, we still haven't figured that out yet because we're still dealing with populations of our patients that are not covered by health care, even though we do have a Reform Act that says that they all should be. We're still dealing with access to care, whether that's remote areas of the United States or just people being able to reach the practitioners that they need to practice. Our workforce is changing. We've seen a major growth within the schools and colleges of pharmacy in the United States. It's expansion within individual colleges of pharmacy, and it's also expansion of additional colleges of pharmacy. If you go back about 25 years, there were close to 80 schools of pharmacy in the United States. And right now we have about 130. If you go back about 12 years, there were approximately 7,000 pharmacy graduates a year. Within the next year or two, that number will be about 15,000 graduates. So we've doubled the workforce of pharmacists. Now, in the meantime, as my role as director of pharmacy, when we had a pharmacist shortage, we did figure out how to utilize technology better. We did figure out how to use our systems that we had better. We did figure out the roles of technicians. So there's going to be a major change within our practice within hospitals. But also we're seeing a big change within the complexity of our systems. And as I mentioned, our patients are moving more toward the outpatient setting. And that's going to impact the care that we provide. What's listed on here is some of the areas that ASHP is working on. And as I said, I will focus mainly on ambulatory care, but I'll also comment as I go through on our work around our pharmacy practice model, what we're doing nationally for provider status, the issues of drug shortages, which was discussed this morning. We're having some major issues around compounding in the United States, so we do have a focus through ASHP on how to help our members both look at compounding within their own institutions or if they're outsourcing these products, how to at least take steps to do what they can to ensure the integrity of the products. We are seeing expansion of residencies, and that was part of my discussion this morning. And then with that, as ASHP as a professional organization, we're trying to figure out the tools and the resources that our members need. So that's where we continue to look at the products that we're providing, at our focus of our educational conferences, and also just meeting topics to make sure we're meeting the needs of our members. So with that, I would like to focus on ambulatory care, just to talk a little bit about the state of ambulatory care in the United States, some of the challenges that we're seeing with advancing practice, and a little bit about the ambulatory care conference that we held a year ago. So, a little bit of information is, as I mentioned, we're seeing our patients in the setting grow. The data shows that the number of our home care patients increased from about 10 million people. We're projecting 27 million patients will need care by the year 2050. This is the aging population. Because of the aging population, we're also seeing an increase in the prevalence of chronic illnesses. We're seeing more of our elderly patients with multiple chronic illnesses. And a lot of these are managed by medications, which means there's a major role for pharmacists outside of our acute care setting. We're seeing a shift in spending from inpatient to outpatient. It used to be about 75% of our dollars, of healthcare dollars in the United States, were spent on acute care, inpatient hospital care. And that has shifted to about 50% inpatient and outpatient. So we're seeing our patients being treated in a different environment. The note I have for aging in place is patients don't want to go in the hospital. That was mentioned this morning. Hospitals are not necessarily the best place to be. They're not necessarily safe. It's not home. It's not where people wish to have their care provided. If this can be provided in an outpatient environment, if this can be provided in a home environment, that is a preference of our patients, so we need to look at that. And that moves us to the movement of medical homes. And that's where we're seeing practice teams available to patients outside of a hospital setting. And then I already mentioned the role of healthcare reform. So, what are some of the challenges we're seeing for bringing pharmacy practice into ambulatory care? When we asked this of our members, I can tell you the biggest one that they said is we don't have good computer information systems. Our electronic medical records do not meet the needs of our patients in an ambulatory care setting. We have a pretty good foothold with computerized medical records in hospitals. We have good distribution services and computer information in our community pharmacies, but we do not have the same in our ambulatory care settings. And then the other issue we're dealing with is between the hospitals and the clinics and the community settings, we don't interconnect. If I'm within one given health system, I may have the information from inpatient into the clinic, but my patients don't necessarily stay within our system. They can have their prescriptions filled any place they want to have them filled. They may be coming to my hospital as an acute care setting that's in a major urban area, but they may live in a rural area. And there's not a good way that we have that information that we can access back and forth. And in some cases, it's proprietary information. So if a patient's having their prescriptions filled at a community pharmacy that happens to be part of a chain, they may not wish to share their information back with other providers. So that's one of the issues. We are struggling to get pharmacists as members of the healthcare team. We have many successes, but we're not there in all settings. And that's one area that we're looking at when we're looking at not only healthcare reform, but provider status in the United States. That we're looking at recognition for pharmacists as members of the healthcare team. Right now, we're not referred to as pharmacists, we're referred to as other healthcare providers. So it's not stated that pharmacists are the ones that should also be on the team with the physicians, with case managers, with nurses. So that's one area that we are still trying to achieve. And then I mentioned the issue with our community pharmacists, is their main role is still dispensing and not in looking at the other provisions of care that we need to accomplish. Some of the other challenges that we have is we want to continue to demonstrate the value of pharmacists, the value in our accountable care organizations, and the value in our patient-centered medical homes. I cited several articles in my talk last evening that shows the value both from a dollar perspective and a clinical outcome perspective of the role of the pharmacist. We need to continue to promote that value, and we have to promote it to the people that are basically paying for us. So it may be within a hospital, it might be the chief executive officers, it might be the decision makers within a health system, but they need to see the value of pharmacists and be willing to pay for pharmacists as we're expanding our services. So we still have our needs on the inpatient side, and we can't just move our patients from the inpatient side to the ambulatory care clinics, or our pharmacists, excuse me. We actually need more positions for practice. And then we are looking for sustainable business models, because it's one thing to get a position justified, but we need to make sure we can continue from a national level on reimbursement. So as I look at some of these challenges, some of the responses that ASHP has had to this is we did hold the Ambulatory Care Conference and Summit, where we brought together thought leaders from around the country and a lot of pharmacists who were interested in ambulatory care practice. And they gave us input on what ambulatory care practice should be. We're continually developing a website looking at ambulatory care resources, and it's a major focus of our strategic plan for ASHP. So as the board of directors, we have directed our ASHP staff to put forward resources to focus on the area of ambulatory care, both to identify the patient needs and also to look at what our pharmacists need for support practicing within ambulatory care settings. We have developed guidelines for minimum standards of pharmacy care in ambulatory care practice. And because of the success of our Ambulatory Care Summit, we actually are going to have a focus session at each of our summer meetings, which is one of our 2 major meetings, that focuses on ambulatory care. The conference was held about a year ago, and there were 4 major areas that we discussed, both in small groups and in larger group presentations. One is looking at patient care delivery and integration. If you think about what we do within a hospital setting, we do very similar things in the ambulatory care setting, but they're not done the same way. Our documentation systems are similar, but they're not the same. The billing systems that we use are completely different. We know we need to bill. It looks very different on the outpatient side. Our distribution systems are different. The work that we do in a team is, we're doing some similar things, but it looks different. And that's as I work with directors and leaders and managers who are used to that platform of a hospital, they also need to figure out what do they need to learn to change to help direct their staff, to help direct their clinical pharmacists, to help direct others about the pharmacist's role in an ambulatory care setting. So it's not just a matter of placing our pharmacists in the clinic, it's a matter of helping them figure out what they need to be doing. I just mentioned we also need the sustainable business models. We have a lot of practice settings that are supported through university systems. And at the University of Minnesota, we have 16 sites that we actually train residents, but that's supported by us as the university. It's not supported, they are not standalone systems. So if we pulled our funding, we would not have the dollars to keep the pharmacists there in most of our clinics. So that's one thing we have to figure out is how do we develop some sustainable business models so we can expand ambulatory care practices throughout the states, throughout the country. We're looking at outcomes. Part of this is research. And part of this is to make sure that what we're doing is of value to both each individual patient and to our patient populations. And then even at the conference and at the summit, we had a lot of people there who worked in ambulatory care settings, but our glossaries are very different, and we need to get on the same page with what we're even talking about. So when we take this word to the CEOs, when we take this word to our government, when we take this information to others, we're giving them the same message and we're talking about the same thing. Some other key areas that we're looking at is, I mentioned provider status. What we're looking at in the States is we're trying to change the Social Security Act. So for the United States, this is Medicare and Medicaid reimbursement, who is a major payer within the United States. And if they pay for something, then a lot of our other third-party payers will also pay for it. So what we're trying to do in legislation is get the pharmacists added. That's a major initiative. ASHP has signed on with many other pharmacy organizations and many other pharmacy companies to try to push this legislation through. And we currently have bills, if you know our government structure, we have bills in the House and the Senate that are moving this forward this year. We really don't know how long it'll take. It might take a couple years. We're hoping to be successful before that. We talked about drug shortages this morning. Currently, there are probably about 250 drugs that are on short supply within the United States. And for ASHP, we have partnered with the Food and Drug Administration, the FDA, to be their provider of information around drug shortages. So if you go on our ASHP website, there is a list of what drugs are currently in short supply. There's dates available on those, and some information when it's known about the reason for the short supply. We've had some major compounding issues within the United States. We had one company that had distributed products that were contaminated, and there were several deaths based on that. So there's a whole body of work being done right now around outside companies that compound, around the stability, the sterility, the processes that are being used by outside companies, and pressure put back on to pharmacies and directors of pharmacies and people who are purchasing these to make sure that we understand where the products are coming from, the production chain, and the integrity of those sources. Now, in some cases, and this specific instance occurred in Massachusetts, and we were using their products in Minnesota. So this is a long way away, and it's very difficult for me as a director in Minnesota to go visit a company that's in Massachusetts to test out their products and to see what's going on. So we depend on others to do this. And that was part of the problem of our system, is some of the people that were supposed to be checking on the processes that were being done were not doing the checks. So sadly enough, this was very tragic within the United States, but it also has caused us all to look at our processes and hopefully improve them. Talked earlier today about expansion of residencies, which we feel is extremely important. And we're also looking at how do we partner with schools of pharmacy for advanced training opportunities. And then we're changing our residency accreditation programs to include community programs and technician care programs. So this is my don't reinvent the wheel slide, because I've mentioned many, many times that we share information. So some of the tools and resources that we have available. This is the platform that ASHP has for our pharmacy practice model. There's 5 key areas that we're looking at as we're focusing on advancing practice across the nation. It focuses on the integration of the pharmacist and the patient care team, the use of technicians and technology to advance our services, the requirements for pharmacist credentialing and training, and then what is leadership within our organizations. And there's a few bullets under each of these that are hard to read, but I'll also refer you to the website. But this is part of what we call our hospital self-assessment, that there's key steps under each of these that we encourage our pharmacy leaders to look at to assess their own departments, and then figure out what areas they want to work on as they're proceeding to advance the practice. We also have a dashboard which has those same 5 areas. And if you see, there's a few of those in the red and a few of those in the yellow. This is coming off of some of our national surveys as we're trying to move practice forward. We're seeing that we're reaching this in some hospitals, but if you're looking at our average, we're not there in many of these areas. So as ASHP is looking at our resources and our initiatives and our focus, we're trying to move these barometers more into the green area because we feel this is important for practice. Currently, this dashboard addresses hospital practice, so we'll be developing similar monitors as we move forward with ambulatory care practices. And then with my don't reinvent the wheel, if you go onto our ASHP website, some of these are on our foundation website and some of these are on the main website. There's a lot of resources that are posted there, whether that's past Whitney Award winner articles, what we refer to it as the C-suite. It's the CEOs of our companies, the chief operating officers, et cetera. There's toolkits for how do you talk to people who have a business background and not a pharmacy background. So what are some things we can do to sell our services? And to take it home a little bit, as we're looking at our practice model change. This is really focused on the care for our patients. When we mention that we want to advance residencies, when we say we're partnering with the schools, when we say we have these training requirements, it really is about the care for our patients. We're looking at our roles of pharmacists at transition points, and that ambulatory care setting is one that we feel we really need to have the pharmacist present, because we're seeing the patient in the hospital, they're leaving our hospital, but they still need care, and they need a connection to that care. So anytime there's those handoffs, it's important for us to focus on the patient. We're asking our members, and I'll throw the offer out to you, is look at your own practices. Find out where your gaps are and what areas you want to address. I can tell you in most cases when hospitals take the assessment survey, they're doing well in quite a few areas, but there's also quite a few areas that they need to improve on. And out of those other areas, they need to pick one or two and focus on how do they improve those as they move forward. Challenge for the pharmacist is, what is your own plan? How are you going to move your practice forward? How are you going to help your department change or look at your own department goals to move things forward? And then I've presented several resources if you're looking at changing your pharmacy practice. We'll hold questions till later, I believe.
Yes.
So, okay, thank you.
Thank you so much, and we are back with the room backed up again with the other people. So I'm happy to have you back from lunch.